So, good morning, good afternoon, good evening, wherever you are, and welcome to this WHO, UNICEF, JICA, and TechNet webinar session. Today, we'll discuss the use of digital technologies to enhance implementation of home-based records, personal health records for maternal, newborn, and child health. In this session, we'll explore the recently launched WHO Digital Transformation Handbook, learn from two country examples about their transitions from paper to digital home-based records, and discuss challenges and lessons learned. You can listen to this session in English and French. To do so, please click the globe icon and select the language in which you'd like to listen to this session. And now let me say that in French for our francophone audience. Vous pouvez écouter cette session en anglais et en français. Pour cela, vous n'avez qu'à cliquer sur l'icône en forme de globe en bas de votre écran et sélectionner la langue dans laquelle vous voulez écouter, donc français ou anglais. We'd be happy to know who's with us today, so you can already introduce yourselves in the chat box and tell us your name and where you're from. Let me see if it's activated. It is activated, so don't hesitate to introduce yourselves in the chat box. If you have also any technical issue, you cannot hear anything or whatever, please let me know also in the chat box, and I'll do my best to help you. If you have any question during the presentation, please use the Q&A box preferably. This is also available at the bottom of your Zoom window. And you can ask your questions absolutely at any time during the presentation, and our panelists will answer them in writing to some of these questions when they can, and also your questions will be selected to be answered at the end of after the presentation during the Q&A session. Finally, this session is recorded and we'll share with you probably end of this week or next week the links to the recording in French and English, as well as the slides by email because you registered and we have your email addresses. So I hope you'll enjoy this session, and I'll give the floor to Annie. Annie.
Thank you so much, Alex, and welcome to all of you. We're so happy to have you join us today for this session, again, organized by WHO, World Health Organization, UNICEF, and JICA with the support of TechNet 21. It's a topic that is of importance to maternal newborn child health world, immunization world, nutrition world, early child development world, and of course to health information systems and digital health world. So we're very happy to go through this session with you, and we look forward to hearing your questions and having a discussion with all of you. Today we have an excellent list of panelists. I'm with the Department of Maternal, Newborn, Child, and Adolescent Health and Aging. I'm here with my colleague, Laura McLaughlin, who's with WHO Department of Immunizations, Vaccines, and Biologicals. We're joined by our colleague from WHO, Nat Ratana Prayul, who is with the Department of Digital Health and Innovation. And then we have our other honored speakers, Hassan Sibomana, the Director of Vaccination Program from the Rwanda Biomedical Center, Ministry of Health, Rwanda. We have Pawan Kumar, the Additional Commissioner in charge of the Maternal Health and Immunization Division of the Ministry of Health and Family Welfare, Government of India. And we have Tomoya Yoshida, the Senior Deputy Director General, Human Development Partner from the Japan International Cooperation Agency. And I just want to thank everyone today for joining us. I'm going to hand over to Laura, and she's going to get us started.
Hello, everyone, and thank you very much. So the outline today is we're going to give a brief overview and some opening remarks around home-based records. And then we'll pass over to Nat, who will just give an overview of the WHO guidance on digital transformation. Followed by that, Hassan will present on the experience, or Dr. Hassan will present on the experience from Rwanda, followed by Dr. Pawan, who will provide an overview of the experience from India, and then we'll have our colleague Tomoya presenting on some of the work they're doing to digitalize the maternal child handbook. So the next slide, please. So we're going to just give a very brief overview on the home-based record and what the home-based record is, because the term is familiar to some and not to others, but I suppose we know it's a record that is essential for primary maternal, newborn and child health, and it's used to record antenatal care, health, growth and development status, vaccinations and other visits from health workers. And it's kept by an individual or by the caregiver. And we know that there are many different types of home-based records globally, and they can come in the form of antenatal care notes, vaccination card only, vaccination plus cards, which include growth monitoring, or combined child health books. And the TechNet 21 website actually has a repository of home-based records. So we try and update that, and so we can keep track of what different types of records different countries have. So that's available to look at if anyone is interested. So at WHO, the next slide, please. In 2018, the recommendations were published for home-based records for maternal, newborn and child health, and the guideline is available on WHO website. Based on the work of this guideline development, 2 recommendations were found, and the first one was related to the fact that the recommendation was that the home-based record complements facility-based records, and that it's useful for improving is recommended for improving care-seeking behaviours, as well as involvement of men in the household and other maternal child care practices, among others. And the second recommendation was related to that really there is insufficient evidence available to determine which type of record is the best format design or is more effective. So it really shows that there's lots still to learn about this area, and then as we move forward, then we also know that there are areas that can be improved. Next slide. So when it comes to home-based records, the paper-based versions, we know that there are common challenges that can actually impede successful implementation of these records, with many countries experiencing frequent stockouts, or unfortunately there are poorly designed records which lead to deterioration over time. Oftentimes we also see that sometimes health workers don't record correctly or record all fields within the home-based record, and retention can be low. So it can also lead to inequity, where we see some health workers with expectations for payment for home-based records, or with some people who forget to bring a home-based record with them to the health facility, can often lead to them being refused services on that day. So in the next slide, we show that we through the joint reporting form, which is a combined form that WHO and UNICEF jointly carry out on an annual basis, we collect indicators related to immunization. We include indicators related to home-based records, and we can actually track annually the number of countries that report stockouts. So we see that there are many countries that actually report consecutive years of stockouts, indicating an issue with being able to supply home-based records within this country. And as I mentioned, this can lead to inequity issues, with people being left out of being able to access services. And in the next slide, we also have an indicator on the Global Health Observatory related to the proportion of cards seen during a survey. So this is an indication of retention of home-based records, and we see that countries with a darker color blue have higher retention, and the lower color blue have a lower retention. And we see that some countries have some retention as low as 20% in their countries. So it is indicative that there are issues with retaining the record, but also we understand that this can lead to issues, and this is often why when we discuss these challenges, the first reflex is many say, but what about digital? So in the next slide, given these challenges and the issues that were identified during the guideline development, in 2022 we published a guidance around strengthening implementation of home-based records for maternal, newborn and child health, with a view for this to be a guide for country program managers to strengthen the use of home-based records within their country. And within this guidance is very clear activities and recommendations or outlines of what countries can do to try and identify where weaknesses are and what can be done to improve uptake and implementation of home-based records. Next slide. And quite recently, a scoping review was commissioned by WHO, and this was to identify what has been undertaken in terms of digitalization of home-based records for newborn, maternal, newborn, and child health. And based on this scoping review, was found that the majority of high-income countries have digital home-based records, whereas no low-income countries were found to have digital home-based records at the moment. Some low-middle income did, but the health domains that had these digital records covered child health, immunization, maternal health, and the scale of the intervention varied, as well as the type of terminology. Next slide. And based on the scoping review, some of the lessons that were learned were that there is potential for successful use of these digital records, but it's dependent very much so on the digital literacy skills within the country, as well as the ownership of digital devices. And that is something that comes up quite frequently in terms of equity, and also being cognizant of gender issues, whereby in certain country contexts that oftentimes the woman may not have access to a digital device. So this can lead to inequity and gender issues. But also there is a necessity for strong internet access, as well as language skills in terms of having this operational language for the intervention. And then, of course, making sure the design is simple, and also confidentiality, as well as security and credibility of data are critical. So we know that there are challenges with paper-based home-based records, but we also have to be cognizant that there are also considerations that need to be strongly considered also for digital. And with that, I will pass over to Nat for her presentation. So thank you very much.
Thanks, Laura. And hi, everyone. My name is Nat. I'm a technical officer in the Digital Health and Innovation Department here at WHO. And we support a lot of member states as they go through their digital transformation journeys. And so one of the most recent guidance documents that I'll introduce here is the Digital Transformation Handbook for Primary Healthcare. So if you go to the next slide, please. So the digital health priorities that member states have outlined for us within the global strategy on digital health, which has been extended to 2027, really revolved around 4 key strategic objectives. And I won't read through them all, but one of them is really about advocating for people-centered health systems that are enabled by digital health. And so the question then becomes, how do we actually create these digital systems that are people-centered? Next slide, please. So one of the key things that we've seen with digital development so far in countries is that a lot of digital tools that have been implemented have actually kind of replicated the issues that we saw with paper. So as you can see in the picture here, in one health facility, there is a large number of registered books, a large number of record keeping that health workers have to be responsible for. And of course, there's all the issues that come with paper as well that Laura had outlined earlier. But what we see now is then this issue of duplicative data entry and poorly designed data entry forms is still replicated in digital systems. And so the question now becomes, how do we actually move away health workers from being data collectors, regardless of whether it's in a paper or digital form, so that they can actually focus on providing services well, and having the tools that allow them to do so. So this includes digital tools that will allow for automated reporting, so they don't have to do their own tallying, tools that will help them provide reminders or clinical decision support, and also the greater scope and context of digital development, ensuring that these digital tools are being country-led and built in countries to ensure that there is sustainability around the technology that supports these health workers. Next slide, please. And so one of the key pillars of our work within digital is really this concept of collect once, use many times. Of course, when it comes with paper systems, if you enter or write down some information in one register book, you have to write it again in the home-based record, and then potentially again in another reporting form. But because of digital, we are able to actually just allow for the health worker to collect once during the care encounter, and then being able to automatically send that and share that with a home-based record, for example, or with a reporting tool, so that the health worker really just has to collect that information once as they're providing that care, but then the personal health record or home-based record is automatically populated with that information without the additional burden on the health worker having to re-enter that information. And so what we're looking to support is for member states to be able to design systems that allow for this to happen, because it really requires systems to be designed in a way that is planned for interoperability. Next slide, please. And so one of the key aspects of this, and what we kind of group together, is what's called person-centered point of service systems. I think when we talk about digital solutions, we often hear things like an electronic medical record system or a lab information system or things like that. But really what we want to focus on is, in general, any digital tool that is facilitating the provision and delivery of health services to individuals at the point of care, which can encompass various functionality and service types. So that includes a community-based information system, decision support system, electronic health record systems, or personal health record systems, or home-based record systems. So any of these kind of systems we've grouped together and just called it person-centered point of service system. So PCPOS for short. And the handbook is really focused on how do we create these kind of systems. Next slide, please. And so the Digital Transformation Handbook for Primary Care is really about how to provide a stepwise approach and understanding of what's called the software development lifecycle. So that's the diagram you see on the right. So understanding what it takes to gather user requirements, design a digital tool, conduct testing, training, and rollout of the tool, scaling that up, and then providing continuous improvement. And it's really a stepwise way to understand how business analysis works, and also using the principles of human-centered design to develop the digital tools. So these are things like understanding what the workflows need to be, how to rationalize the data requirements from paper registers into a digital data dictionary, and then understanding the user needs in a way that doesn't replicate the issues with paper. And so this handbook is really for anyone who's interested in developing a digital tool for health. Next slide, please. And one of the key sections in the digital transformation handbook is really understanding the user requirements. So this comes down to why certain systems, why paper systems or even digital systems aren't designed well, is because oftentimes this step is kind of skipped, where you don't actually understand what the health worker needs or what the individual client needs within the systems that they're using and the tools that they're using. So we have in the handbook a clear set of steps for how do you actually get to know the users, how do you map the workflows they need, how do you prioritize requirements that they have outlined, and then those outputs that you would produce in following those steps could be used to clearly articulate the needs to a software vendor, and practically even put that information into an RFP or request for proposal to then onboard a vendor. And also some countries are using this work to use it as a benchmark for assessing systems that already exist in countries. So next slide. And so for a health program manager who maybe not be too familiar with digital, I would say this handbook is actually primarily written for you. It's really using principles that I would say a digital health practitioner is often familiar with. The concepts of business analysis and requirements gathering are standard across any digital development. So not just within health, but in finance or agriculture, any digital tool requires these steps. But we contextualize it so that a health program manager can understand how these digital tools are developed, so that you can also manage these projects appropriately, articulate the program needs so that you can have that negotiation discussion with the digital teams, and then also, more importantly, prevent any sunk costs to the poorly designed systems, because we all know that digital technologies are expensive. So you should want to be sure that the investments that are going into them are effective and will lead to something usable, and also reduce any potential redundancies in those investments as well. And for a digital health practitioner, this provides just a refresh of best practices, templates throughout the workshops, also understanding the methodology behind what we call the SMART Guidelines program of work. I won't go into too much detail here, but it's the SMART Guidelines are another resource that we provide to member states to allow for them to develop digital tools in a more efficient and well-designed way, and then also support capacity building efforts. So next slide, please. And so I wanted to just kind of emphasize that the handbook is really just one piece of the puzzle to understand how to design an app. So what you can see in this diagram here, though, which is a lot that comes in, the applications with the specific interventions is really just one piece of how to do digital. So you don't want to just create a home-based records app and even though it's well designed, call it a day, because that application needs to exist within this greater context of the various digital tools that are required to support the health system overall. Next slide. And so we do have a large number of other documents and handbooks to support countries throughout this entire process. Even this whole how to do digital and how to invest in digital at a high level is outlined in the Digital Implementation Investment Guide. And in that, we have the linkages to the handbook and where the handbook would actually fit in more appropriately. And then I've also linked here the Digital Adaptation Kit for Immunizations, which was recently published. So if you're interested in taking a look into specific data requirements or what the outputs of following the handbook process would look like, it looks like what we call a digital adaptation kit. So you can access that here as well. Next slide, please. And so that's to say within this greater scheme of how we're thinking about digital is that this handbook really focuses on the methodology and how to design these digital systems, but that also works with the SMART guidelines, which are the standards for these digital systems. And then if you have these standards at tools that are used by a healthcare worker, as well as the tools that are held by the individual, you could have these ecosystems where the digital tool that's used by the health worker that's adopting a certain standard can then be automatically populated to a personal health wallet or a personal health record that then an individual carries with them. Next slide, please. So with that, the links are here and happy to answer any questions. But in the meantime, I'll hand over to next speaker, Hassan, for his presentation. Thank you.
Yeah, thank you, Nat. So my name is Hassan Sibomana. I'm the EPA manager for Rwanda. So I'm very happy actually to present to you our experience in digital solutions. I will mainly focus on digital solutions we are using in the vaccination program. So this is the outline of my presentation. So we'll actually go through background, key technology we're using in immunization, and then what we're expecting from these digital solutions, and then what we have provided as input to health facilities, and then conclusion. Next slide. So as background, vaccination program used to use registers, vaccination card, and in general, the way actually have been using to collect data actually it is a traditional method using paper-based system, which are very, very expensive and also very hard to keep records and also inaccuracy in data, because actually when data are collected using paper and also the compilation is being done to report. So I have seen that actually it was very, very complicated and we were having actually inaccurate data. And currently we are trying our best to make sure that actually with these solutions, all those issues can be solved. Next slide. So as I said, actually have seen that actually paper-based system is very, very expensive. As we did cost analysis, we have found that actually have been using more than 300 million Rwandan francs for printing on an annual basis. But currently, because of using digital solutions, so we have been able actually to save all that amounts. So meaning that actually it is not only we are keeping very good data, accurate data, but also we have been able to reduce the running cost in the vaccination program. And we have seen that actually we are no longer having issues with delayed reporting and data loss risk. So, and there was an issue of fragmentation of data. So currently, actually, you can be able to know the real number of vaccinated children on a daily basis. So this is very important because actually can you imagine actually to have information of vaccinated children in all health facilities across the country? So this is something really very, very important. Next slide. So technologies we are using, actually all software or digital solution we are using DHIS2 based. So now we are using HMS for data reporting on monthly basis, but also we are using immunization electronic tracker, which is also under DHIS2 instance, but also we are using vaccine logistic management information system. So all of them actually they're using the same instances DHIS2. And then DHIS2 actually it is not something new, so it has been it has started to be used in our health system 2012. But this immunization tracker is very new because actually we started to design it in 2019, and actually it was operational in 2020, and it is the same system we used actually during COVID. And then after COVID, we have seen that actually it is a very good one. So we opted actually to use the same system for routine vaccination. And currently we are fully digitalized. We are no longer using paper method for data collection and also reporting in our vaccination program. And later on, we have seen that actually we need really also to digitalize vaccine management and vaccine devices. And currently, even vaccines, logistics, and vaccine devices actually it is also digitalized. Next slide. So when actually we introduced the immunization aid tracker, so there was so many expectation. So the first one actually it was just to close follow-up defaulters and reduce dropouts, because actually this is a digital system where actually you can extract actually the list of vaccinated children and those one who missed their appointment. And the second objective actually was to save funds allocated to printing and the registers we have been distributing to all health facilities. As you can see, on only vaccination cards, we have been using 300 million Rwandan francs. So actually, it is equivalent to almost 220,000 USD. So it is a huge money. But also there was an issue at central and the hospital level to make closer follow-up of ongoing vaccination sessions, because actually we used to wait for the whole month to hear from health facilities to get actually data of vaccinated children. But today, at the end of the day, actually we can be the list of all children vaccinated across the country, and also the improved data quality of data. Now it is also improved because actually we can even provide real-time feedback, and also we tried our best to use the same system actually to integrate other systems, other interventions. So currently using immunization aid tracker, we have integrated growth monitoring, we have integrated maternal death monitoring, and also we have integrated mosquito net distribution, so which is helping a lot because actually now it is very easy actually to follow up what is going on in all health facilities. Next slide. So there is some investment. It's not easy actually to start digitalization. So you need to train people, but also you need some other resources like IT equipment. So for us, we started in 2019 by training all health facilities, at least one nurse, data manager, and the head of the health center. And also at a hospital level, we EPS supervisor and also data manager and the one who is in charge of monitoring and evaluation. So we are always conducting this kind of training so that we can have so many people trained. But also we have been able to mobilize funding from Gavi HSS to procure desktop and also tablets distributed to health facilities. And we supported also health facilities actually to be connected, because definitely this is a web-based systems. So we need to have a very good internet. And also we have been able to integrate the immunization aid tracker with CRVS. The birth registration now in Rwanda is supporting vaccination program, because when we are receiving actually a newborn in vaccination program, So we don't need actually to ask the caregiver of the parent or the parent actually all information related to the child, because actually what we need, it is a national identification number, and then we can extract data from birth registration. So those two systems actually talk to each other. So when actually we are receiving a child who is not registered in CRVS, so we can easily push data to CRVS, but also we can pull data from CRVS when actually the child is the first time actually to attend vaccination session. Next slide. So we had very good support from the high leadership of the Ministry of Health, because as you can see, actually there was different correspondences from the Ministry of Health to health facilities. So the first one actually it was in 2022, where actually our minister was highlighting that actually we are phasing out paper-based system. And you can see actually there was a follow-up one actually from also the minister reminding all health facilities that actually it is no longer accepted to use paper-based method to collect and report vaccination data. So currently all of them, because of this support we had also from the high leadership of the Ministry of Health, so all health facilities now are using the system, so the performance is 100%. So now what we are doing today is just to make sure that actually we are reinforcing and make sure that actually the data quality is improved, making sure that actually completeness is 100% for all variables actually we need to collect. But also there is a way of enhancing the system so that it can be easier to all users to use the system, and also guide them how to use the system. Next slide. So it was very important also to highlight responsibilities of each trained staff. So at health centers, actually, there is a nurse vaccinator who is receiving children and vaccinate them, but she is or he is the one also to register vaccinated children into the system. So there is also the role of the data manager who is supporting and guide the nurse during the use of the system and perform regular data analysis. Because actually, at the end, what we need just to make sure that actually even collected data can be analyzed and be used so that we can take decision based on evidence. And then the head of the health center. So this one also is very key, because actually the leadership of the health facility is very important to make sure that actually the system can be used. And then the role of the hospital. So actually it is just to supervise and also provide technical support wherever needed. Next slide. So this is the how actually the systems is built. So we have actually CRVS. This is actually where children are being registered in CRVS. It is the system actually being used now in health facilities. So before 2002, actually the system had been it was being used actually in administration, in the district office or sector office, but today the system also is being used actually in health facilities so that it can be easier for newborn actually to be directly recorded into the system. So the system actually using data for immunization, and we are also we are only focusing on birth registration. So those newborns, actually, they are the one actually we are always expecting for vaccination. And then the same system we are using, so we have integrated with growth monitoring. We can also collect data on adverse event following immunization. And also we can input also some special events when there is any vaccination campaign. Actually it is also easy actually to create a new event within the system, and then the system can also send SMS alerts so that it can also remind parent or caregivers to bring children for vaccination. And then we have seen that actually the same system is supporting a lot, because with the same system, we no longer request our healthcare providers actually to provide monthly reports, because the system itself at the end of the month, it can push data in HMIS. So we no longer need actually people to sit and draft monthly reports. So the same system actually you can see it is somehow reducing also the workload of healthcare providers in health centers. So we have also the vaccine logistic management information system. So this is the same system actually we are using also for vaccine management, and we are trying now to see how we can link it to the immunization e-tracker, so that the two systems can talk to, to each other, so that you can see consumption of vaccines and also number of vaccinated children, so that it can be easy also to provide feedback wherever it's needed, because actually it is helping also to see what is the wastage rate of vaccines actually are using. And then this same system actually can be used also by caregivers and also parents, because themselves actually when the child is already vaccinated, so the caregiver or parent, they receive SMS thanking them that actually the child has been vaccinated. But within the same message, actually there is also a link where they can download a vaccination card for the child. So meaning that actually we are also contributing to the reducing the way actually paper are being used. It means that actually we are also contributing to climate change and also serving our environments. Next slide. So this is the performance of our system, the immunization electronic tracker. So you can see that actually at the beginning in 2002, actually the performance was not very good, but you can see that actually starting March 2023 up to date, actually now performance is very good, 100%. It means that all health facilities are using the system. So it is very important to highlight, because actually we don't want actually to lose also data. It is something we are following up on daily basis to make sure that actually the system is being used. Next slide. So with the same system, actually, the system is supporting us actually to record individual data. So actually, it is helping also to manage appointment, and also we can see easily children who miss their appointment, and also the same system can send SMS, and also it provides digital vaccination card, as I said, and also we can have a real-time data access, because actually it is a web-based one. So wherever you are, actually you can access the system, and also we can support easily healthcare providers, because if there is any issue, so we can easily communicate with them using the same system, because actually even reference materials are uploaded into the system, so that it can be easier to health workers actually to check. And we think that actually also the same system are having a very good public health impact, because the same system is playing a crucial role in improving vaccination coverage, and also we are monitoring very well actually everything happening actually in vaccination services. Next slide. So this is actually example of the digital vaccination card. You can see that actually it is even actually being generated automatically in different languages, in our local language, Kinyarwanda, in French and English. But also you can see that actually it is also integrating growth monitoring. So that growth monitoring chart, actually it is also being generated automatically. But you can see that actually you have also barcode. So it means that actually you can scan and make sure that actually the card actually is authentic. So this is very important. Actually, this replaced actually the one we have been using, which was very, very expensive actually to print. Next slide. So, and then I would like to talk a little bit also on vaccine logistic management information system. So this is also the system we are using to make sure that actually vaccination program can be fully digitalized. And health facilities actually, they can use the same system to request and distribute vaccines. It is helping also on monthly inventory management, and also on the alert on soon to be expired product. And also when there is some stock out, actually it can flag that. And also we can forecast using the same system. And we think that actually this system is going to continue helping us actually in accountability and transparency of vaccine management. Next slide. So as conclusion, I would like to say that Rwanda's transition to digital immunization tools has reduced printing and administrative costs. So it improved data accuracy and access, and actually it strengthened vaccine logistics, and also it enhanced the efficiency and the follow-up. And the digital system reduced workload for healthcare providers and waiting time for client, and also accessing real-time data, because actually, as I kept saying, actually this is a web-based tool, and also improve the vaccine management. So I think that actually this was a major step forward in building sustainability and the modernization systems. And before I conclude, also I'd like to thank Gavi, because most of the funds we used, actually it was support from Gavi, and also WHO and the UNICEF country office. They have been supporting a lot actually to make sure that actually we can use the same system. And as you can see, so this system actually it is not expensive, because DHS2 is free, so we did no license is required. So it means that actually all countries can use the same system. Thank you. Now let me hand over to Dr. Kumar. Thank you.
Thank you very much, and good evening, good afternoon to everyone. So in coming 15 minutes, I will be discussing about UVIN's digital initiative, which is being launched by our Honorable Prime Minister on 29th of October 2024. Next slide, please. As we know that India is a very big country, we have a cohort of 26 million newborns. We have a cohort of 29 million pregnant ladies. We conduct almost 1.2 million immunization sessions every year. We have a cold chain network of more than 30,000 CCP points. We have 11 vaccines for 12 vaccine preventable diseases. So the quantum, the scope and scale is very large, and managing such kind of a huge data for immunization was a very Herculean task. So country decided to digitize all these processes into a IT platform, which we call as a UVIN. UVIN means winning over the universal immunization program. Next slide, please. So in our country for immunization, we have three pillars of IT intervention in immunization program. One is EVIN. EVIN is an electronic vaccine intelligence network, where all inventory, all syringes, needle, vaccines, they are mapped into the EVIN portal. Even the cold chain points and the cold chain equipments with the temperature loggers, what is the temperature of each machine by sitting in one state or in one place, we can know as a manager what is the temperature of ILR or a deep freezer into that particular place. So that was a pillar number one, which we have started in 2015. With that learning during the COVID era, we brought another app, the IT platform, CoWIN. All our COVID immunization that has happened with the CoWIN platform. Who is administering the dose? What is the batch? Which company? Everything is mapped on the CoWIN that we started in pillar number 2 in 2021. With these IT learnings in our country, we have graduated to UVIN, that is winning over the universal immunization program, which facilitates registration, data recording, and tracking of vaccine doses administered to every pregnant woman and child up to 16 years. It helps us to plan vaccination sessions, updating vaccination status digitally on real-time basis from the last mile of service delivery by the vaccinator, which we have started as a pilot in 2023, which was launched officially last year by our Honorable Prime Minister. Next slide, please. So what are the challenges before we have brought the IT platform? Difficulty in monitoring. How to monitor the data of 26 million newborns and 29 million pregnant ladies who are getting TD vaccine? What about the private sector immunization data, where that is going? That is on a paper-based. Mobility of beneficiary. If my beneficiary client is moving from one place to another place, so can the tracking of a data can happen? No, because if they forget their immunization card, how to handle that situation? Then Awareness about the session. If you are moving out of your town, how many immunization session, which site, which facility, how to map that. That is a problem at that time. Inequity in immunization coverage across states and UTs. Individual tracking, name-based tracking was not possible. With these challenges, India has brought a IT platform that we call as UWIN, where live reports are available national level till session sites, starting from village, sub-center, primary health center, community health center, district hospital, and so on. Inclusion of private sector. The private partners which are doing immunization, let us try to capture that data also. Anytime, anywhere vaccination. Services can be availed anytime, anywhere, because everything is in your IT platform mapped. So we know if you are moving any district, any state, any place, you can have a vaccination then and there only. By just putting your PIN code of that particular area, you will come to know how many immunization sites are there around your stay, where you are. Visibility of vaccination sessions. Individual or a community or a vaccinator, anybody can see how many immunization sessions are there, where they are being conducting. Reaching out to beneficiary till the last mile means the client which is in the village on the periphery, just reaching to them with a mobile number, because it's a name-based repository of our data. Real-time tracking, you can have a real-time data. Next slide, please. So left side is our conventional MCP card, what we call the maternal child protection card. Same we have brought in a UWIN as a digital QR-based immunization card. QR-based means whole data is embedded into the QR. You can see that the particulars of that individual child or a mother in a digitized immunization card. Next slide, please. So UWIN structure is based on a demography. In our country, we have a local government directory. In the villages, we have provided LGD codes, village, ward, sub-district, districts. Then we have a health facilities. Then we have a cold chain points. We have a local bodies, the wards, the state. So all these, they are being mapped as per the standard protocol of LGD into our UWIN platform from national level till the session site, which is happening at a sub-center or village level, or which is an outreach activity in a field itself. So all activities, all immunization session, who is going to vaccinate, all they are mapped from village, delivery point, and so on. Next slide, please. So UWIN module, the basic structure, it has 5 modules. One we call as administrator module, which helps the program manager to plan the sessions and manage them. State, district immunization officer, health facility manager, the PHC, the medical officer, they are designated as administrators to manage that module. Then we have newborn or a delivery module, which is being used in the hospital once the pregnant mother is delivering a child. Basically, the capturing the data of that newborn child then and there only within the hospital where the delivery is happening. So birth doses, they are given then and there only. So data by name, mobile number, mother, father details, they are captured then and there only once the child is being born, which is being used by medical and paramedical staff. Then is a vaccinator module, who is doing actual vaccination. They manage that module. They conduct the session, register and record each vaccination event. That in our country, that is auxiliary nurse and midwife, which is the lowest point of a vaccinator. Then we have a mobilizer module. In our community, in our country, we have a ASHAs, the accredited social health activists, which are a link worker between the community and the health facility. They mobilize the children which are due for vaccination. They mobilize the pregnant mother which are due for the TD vaccine. And they also have access of UWIN. Within their mobile phone, they can see how many children or mothers they are due for the next vaccination. So they can mobilize from the field itself. We call it a mobilizer module. Then is a citizen module, means which is in a public platform, which is available to the public. They can see the session sites, they can block their prior registration, they can block their session sites, they can block the session slots also through this, and we call it as a citizen module. We call it a citizen module because it has access of anybody who is residing in the country, and it accesses through their mobile number. They can register themselves through the mobile number into this module and can download their QR-based mobile this certificate, also QR-based digital certificate. Also, they can book their appointments also, and so on. Next, please. So digital imprint of the vaccination life cycle on the UIN, basically. We have a pregnant lady, which is being registered in the UIN. The due course of time, they do a delivery, and they do deliver the new babies. So delivery outcome is recorded in the UIN itself. Once that delivery outcome is recorded, during that time, the particular features they are recording. What is the weight of baby? Is it a normal delivery or a cesarean section? So what is the weight and how to move forward? So all data is being captured then and there only, along with the parents' detail. Then newborn registration and birth doses, they are given then and there only. So this means once the child is captured as a 0 dose during that time, so he or she can be followed, tracked anywhere in the country. So which will help us to reduction of 0 dose children also. Then we have age appropriate infant and child vaccination from 0 to 5 years, 10 years, the TD vaccine, 16 years, we have a TD vaccine, then adolescent vaccine and so on. And then that adolescent is becoming a pregnant mother again. And this life cycle approach is being followed in our country. Next slide, please. So this is the URL which is available, and anybody can go to the digital site, can see. And moreover, these landing page, all these data, they are available in all local languages in the country. We have 12 Indian languages, and this is a multilingual portal in our country, which is web-based as well as a Android app-based. And all information regarding UIN, troubleshooting, national immunization schedule, all they are being hosted on the landing page itself. Even we have a frequently asked question both for the citizen and vaccinators on this web page. Then this link to download UIN Citizen mobile application is also there. We have a helpline also if somebody is finding any difficulty to register or finding any location near to their home. So we have a 16x7, means the 16 hours in a day, this helpline is working in our country to have to take care of the troubleshooting. Next slide, please. So this is a more just snapshot of a mobile application, which is Android based. Soon we are working for the iOS system also, where you can register to the Android app as a member, whether you are a parent or a mother or a father or whatever you are, then date of birth, then full name, male, female. This is how the registration is being done in a citizen application. Then you have a UIN vaccinator application also as a healthcare provider, as a vaccinator, how to register myself to become a vaccinator into this app. It's a very easy app. Anybody can access and anybody can operate this app as a mobile user. Next slide, please. So the crux of this UIN is accurate data record management. Now you have a name-based repository. So your exact data is there. It's registration by self or ASHA or ANM, it is available. Generation of permanent digital vaccination record, digitally QR-based certificate. You go anywhere, anywhere, you can download anywhere that certificate, whether you need a admission of your child in a school or a college. This is a permanent record which is available with you. The name-based recording, identification and coverage of 0 dose children. That is the most important for us. Left out and dropped out beneficiary. You have a mobile number, you know the name. You have a mobilizer modules. They can call, where are you? Why you haven't come for the vaccination? If they have moved to the another state or another place, even through that app, they can get a vaccination near to their residence, and we can guide them. If you are in another city, please get vaccination there also. If we conduct kind of a campaigns, that information can also be captured in the UIN, which we have called as a immunization program in the last 2023 as a IMI intensified mission. In the whole database was captured through the UIN itself. Then initiation of a longitudinal health record for every child through generation of child Ayushman Bharat health account. We create a health account of the child then and there only through the ABA. In the future, once they are growing, the whole data can be captured and can be linked with the ABA ID, and you can have access. Third is the most important. The fifth point is automated text SMS services. Once you registered in the UIN, you get a SMS that you have been registered. Once you get a vaccination, you get an SMS with a link that you have been vaccinated with that TD or any kind of a vaccine. Then link is there. You download that link. You click that link. You can download your QR-based certificate. Then a due dose reminder. If you are due for a next dose 3 days before that, you can SMS that your dose is due. You please come to this health facility. You can have a next to your dose. So this is the beauty of this UIN portal, which is being created in the country. Next slide, please. The mode of registration in UIN, Registration can be done by beneficiary or by ASHA or a mobilizer before they arrive at the session site. Then is a online self-registration by beneficiary through UWIN Citizen module. They can do themselves also. Walk-in, if anybody is walking in a health facility, the vaccinator can do a registration then and there only. Then assisted registration is also there. Guided registration of beneficiary through support of UWIN technical helpline, which is working 16 into 7 into 365. We have a helpline number. If somebody is finding difficulty how to get registered, they can get a helpline number and get registration themselves. Next slide, please. So automatic SMSs, notification to beneficiary. This is a prototype. What is the language we get once we get an SMS? Like this, dear so-and-so, your child Vihan Kashyap is successfully registered for UWIN. Your vaccination reference ID is this, and you can visit this. This is the registration once you do. Then is a vaccination acknowledgement with link to download e-vaccination certificate at the time of vaccination. This is the prototype, how you get a SMS. Dear Padmani, your child Vihan Kashyap is vaccinated successfully on this date, this time. Download your certificate. You click this link, you will get a QR-based certificate. Due dose reminder 3 days prior to due dose of vaccination. Dear Uma Devi, your child baby of Uma Devi, vaccination is due on 23rd of April, so on. So these are the prototype how you get SMSs on a real-time basis. Next slide, please. So this is a vaccination module which we call it an offline module. Because our country is a huge country, we have a hard to reach area, and to reach in those, we have an offline module also. So if you don't have an internet connectivity, you get that internet connectivity whenever you move to the net connectivity. So whole data is synced through the offline modules also. That is also in the offline module for all of us in the country. Next slide, please. So there is a vaccination confidence module also in the UWIN, which is we call it a vaccination avoidance behavior. We can map those communities or those areas where the resistance or hard to reach area people are there. So in a GPS or a GIS system, we can monitor those people, those communities where the kind of a resistance is there, the health people or a hospital managers or our community people or a CHO, whatever they are in the field, they can come to know this is a site where the resistance families are there, and that will help us to for maintaining the database for that. Next slide, please. So validation vaccination events ensuring correct data entry is also there because this is a OTP based data security, and we are very much serious about the security of the country data also for the UWIN, for the pregnant mothers and for the newborns. So we have a OTP system. If the OTP is not being delivered, we have another alternative validation system also, that is a 4-digit PIN, which is being created at the time of introduction of a registration. Then multi-factor passwords are there, the year of birth confirmation is there. So we use these authentication system also when the child is coming for the vaccination. Means the X child who has come is exactly the same child who has been registered into the UWIN system. Next slide, please. So grievance redressal mechanism is also there. If somebody is having a grievance that your certificate name is wrong, your date of birth is wrong, your particulars, they are wrong. So we have a call center which is working 16 to 7. Then you have UWIN web portal also. We have in the landing page, you can register your complaint. And the back end, we have a helpline people also at the level 1, level 2, level 3, and so on. If the grievances, they are not being handled at the front end, they are being raised to the next higher level. This is how the grievance redressal mechanism for the data sharing, data correction, if you are not able to register and getting timely SMSs, then the kind of a ticket system is being generated. You can just track your grievance also, whether it is being resolved or not. Next slide, please. So this is the achievement as of now. Almost 100 million registered beneficiaries, they are there in the UWIN system. Almost 18 million vaccination sessions they have been held. Almost 10 million deliveries they have been recorded on the UWIN. Almost 397 million children they have been vaccinated through the UWIN, and almost 90% of the sessions which are being planned through UWIN, they are being actually held through the UWIN itself. This is the achievement of the program. This is how the program is going in a positive direction. Next slide, please. So what are the outcomes? Outcomes are that it improves the access anytime, anywhere vaccination services. Convenient to the client, convenient to the vaccinator, ease of use, inclusive participation of private sector, government, defense, any organization, we are ready to give access for that also. Second is the electronic vaccination register, which is paperless, QR-based vaccination certificate. Offline module is there. Planning of vaccination campaigns we can do through that. The real-time dashboard, intensification of routine immunization, triangulation of data, vaccine supply, coverage, AFI, even AFI is being linked. We have a Safe Act, which is being linked with the UN. All the minor AFI, they can be reported through UN itself. Then reaching the last mile by name-based tracking system, automated due list generation, automated SMS generation, mapping the vaccine hesitant families. This is the overall snapshot what all features we have for the community as well as for the vaccinators. Next slide, please. So impact means the VPDs, they will be prevented. The all 11 vaccine which are there for 12 vaccine preventable disease. Once we are having a full immunization coverage, then ultimately it will reduce to under 5 mortality, the infant mortality. That is the impact of this IT intervention. Next slide, please. Thank you very much. Over to the next speaker, please.
Yeah, thank you, Pawan. Good morning, good afternoon, good evening, and thank you very much again for joining us today. I'm Tomoya Yoshida from JICA Human Development Department. I'm covering the health programs of JICA in Asia and Pacific, and also I cover the digital health issue. In this presentation, I'd like to introduce our ongoing activities of development of Digital Maternal and Child Health Handbook, or MCH Handbook, as a digital public goods. Our activities aims to improve maternal and child health by offering digital value proposition to the traditional paper-based MCH handbook, which are used widely in many countries. And okay, let me begin with the background. Next slide, please. Yes, next, please. Yes, as you already understand, the use of digital technology has become indispensable in all elements to achieve universal health coverage goal. The figure here is taken from the WHO guideline, digital health guideline, and it's understandable that physical intervention alone cannot achieve the health system goal, but we think that digital technology fills those gaps. Next slide, please. Yes, many countries have adopted paper-based MCH handbook over the past decades. As you may know, these handbooks are designed to provide the mothers with guidance and record-keeping tool from pregnancy through early childhood. It is an integrated home-based record for MCH. As this graph shows, JICA has cooperated with more than 30 countries at the various stage of introduction of MCH handbook. Many countries like Indonesia, Vietnam, Ghana successfully expand the use of handbook nationwide and institutionalized in the health system. With smartphones becoming more common, even in low and middle-income countries, we see an opportunity to digitalize this tool, and not a few countries request JICA to support digitalization of this MCH handbook. In terms of digitalization, we already have a very few experience, as you can see, Palestine refugees and a very small scale trial in Senegal. Okay, next slide, please. Yes, next slide, please. Okay, we should emphasize that digitalization is not just about converting paper tools into electronic format. It's about creating new values. So recognizing the added value of digitalization of MCH handbook is very important. In the following slide, I'd like to share the added value of digital MCH handbook from different angles. As this graph shows, this digital MCH handbook can contribute in 3 areas, like education, communication, and recording tool. And MCH handbook could support both clinical care and positive behavior change of mother caregivers and communities. Next slide, please. Okay, so this slide shows that digital solution for MCH can address most of the WHO's 9 category of health system challenges. This example addresses common challenges such as mothers forgetting vaccination appointments or missing checkups. Digital MCH app can send reminders for the timely. For healthcare workers, it improves efficiency and data accuracy. Yes, next slide, please. Yeah, digital MCH solutions can personalize care and services, automate data information sharing, and enable real-time decision-making. They help transform health systems through digital transformation, or DX, by integrating with local healthcare workflows. These solutions can solve problems that analog methods simply cannot address, such as data loss, or real-time alerts, or tailored guidance based on individual risk. In short, the goal is to use digitalization to bring smarter, more efficient, and more impactful care. Next slide, please. Yes, this slide compares digital and analog approaches. Analog methods like paper-based handbooks are familiar, low cost, and don't require electricity or internet. However, they have limitations in prompt updates of the contents or data sharing and integration with the health information system. So digital methods, on the other hand, can offer real-time communication or centralized data management and personalization. Yet they may face challenges such as digital literacy or infrastructure gaps, but over time, as ICT infrastructure improves, the relative advantage of analog tools will likely decrease, and making it essential to prepare for the future where digital tools are more widely utilized. Okay, next slide, please. Yes. Thank you. M600 should be graded according to the situation of each country, and JICA has supported the introduction of MCH handbook in line with the national context. But for digitalization, we thought it would be possible to develop a standardized tool and apply it to each country, rather than developing one for each country, by taking advantage of the benefits of digital technology. For this reason, not only develop this tool based on WHO guidelines, but also we are considering registering this prototype as DPG, or digital public goods. So this slide shows that the DPG process. DPGs are open source digital tools that support the achievement of sustainable development goals. They are designed to be accessible, reusable, and adaptable across countries without relying on a specific vendor or platform. For the MCH handbook, using DPGs allows us to develop modules that can be shared internationally, reducing duplication and promoting interoperability. We also hope that it ensures sustainability by building on community-driven standards and open technologies. Next slide, please. Yes, this slide shows our approach to develop the digital MCH handbook prototype as a DPG. The development process includes defining functional and non-functional requirements, and creating mock-up screens and validating use case with partner countries to jointly conduct the proof of concept, or POC, with that. We are aligning our process with DPG standards, which include modular design and documentation for global sharing. So the goal is not just to build an app, but to create the usable digital resource that can be adapted and implemented in various settings. Yes, next slide, please. Yes, next, please. Yes, this diagram illustrates how the digital MCH handbook functions within the broader health system. On the top, we have mother and families using mobile app to record health data, access education materials, and receive reminders. In the middle, healthcare providers use digital tools to view records or deliver care and input data. On the bottom, health administrators aggregate this data for planning and monitoring. All components, mobile apps, EMRs, and and national health information systems are connected through a centralized MCH server, seamless data exchange, and ensuring continuity of care across all levels. Okay, next slide. Yes, this slide outlines key functional requirements for the digital MCH handbook prototype. The system is modularized at 4 layers: front-end, logic, data exchange, and data storage. For example, the application calculates the next visit date using past record and predefined rules. It also imports data from external sources like EMRs to reduce manual entry. Educational content is tailored based on the mother's record and prioritized using a rule-based engine. And these functions are designed as flexible modules, and some are common to all countries, and while others can be customized based on national needs. Yeah, next slide, please. At present, we consider those 3 countries as a candidate for our proof of concept or POC phase of the digital MCH handbook. We are currently communicating with government of Bhutan, and we will soon contact Honduras and Zimbabwe. These countries were selected based on the existence of or future collaboration willingness of introduction of digital MCH handbook and the opportunities to integrate with their national system. So during the POC phase, we aim to test the digital MCH handbook, usability, data integration, and health impact in real-world settings. The findings will inform improvement and scalability for wider adoption, as well as more usable tools as BTC. Okay, so next slide. This slide outlines the overall timeline and next steps for the development of digital MCH handbook. The initiative is structured into 4 phases from 2024 to 2026. Step 1 focuses on research, requirement analysis, and preparation. In step 2, we will begin prototype development and pilot planning. Step 3 involves conducting the pilot implementation in selected countries, and followed by monitoring and evaluation. And finally, in step 4, we will define the system based on start and prepare for wider distribution. Our goal is to create a scalable, adaptable digital tool that align with global and national health strategy in partnering with various stakeholders. This is the end of my presentation. Thank you very much for your attention. Back to you, Annie.
My sincere thanks, Nat, Hassan, Pawan, and Tamoya. Excellent presentations, really of interest. You'll see all the questions in the chat. If the colleagues, participants can stay on till 14:30, we're going to try and ask at least 2 questions to each of the panelists. I know the panelists have been trying to answer in the chat. Panelists, please be short and sweet, but I'm going to pose these questions because I feel they give a flavor of what were some of the concerns. So Nat, let me start with you. There was one question from June Aim, and someone else had asked about, private sector, and private sector being such a big start. How does the handbook, how do these digital systems, how do you make sure these can also include and reach and be useful for the private sector? So Nat, that's one question for you. And then the second question for you was, does the handbook provide guidance on best practices about how to transition programs?
Yeah, so definitely yes to the second one. I think that's really structured around what the handbook is supposed to be for, is to understand really how to move from paper to digital at that methodological level. In terms of engaging private sector, so I think the biggest gap that we see oftentimes is that those within government, not just ministries of health, but government in general, often are not up to date with understanding what private sector is doing, especially when it comes to digital technologies. So the handbook is intended to also bridge that gap so that within ministries of health, you're able to really understand what private sector is doing, within the space. So then it's easier to actually govern that. But I think the other key aspect too is that the handbook is just one piece of the puzzle. So once you understand what they're doing and are able to provide outputs that can be used as benchmarks for assessing private sector, there's also all these other aspects of governance, policymaking that need to come into play as well. So I won't go into that rabbit hole. I'm happy to discuss later on, but I think it's just important to remember that the whole governing aspect of really knowing how to establish public-private partnerships in a structured way within your country context is still critical here as well.
Thanks. Thank you, Nat. That was great. Hassan, you generated a lot of questions with your presentation. And one of them I'm just going to ask because I don't even know what the words mean. And it shows that we have a digital audience besides an MNCH and a health systems audience here and an information system. So one question was, is VLSM implemented on DHIS2? And the reason why I'm posing that is because to me, it's a question I think what people are trying to get to is integration and ability to, interoperability between systems. There was a question that popped up, and I know it's of special interest to all of us, given the immunization and the MCH audience, about this integration between immunization and other programs. And Hassan, did you feel this was straightforward? Is that easy to do? You did say that, it's easy to add other vaccines, but how do you see the working with MNCH programs? And the last question for you, Hassan, I picked three for you. It was a whole question, given this very chaotic time and funding shifts, the questions of sustainability and what was done for sustainability. So over to you, Hassan.
Yeah, thank you, Annie. So VLMIS Vaccine Logistic Management Information System is under DHIS2. And DHIS2, as you know, actually is a product from University of Oslo, and it is free of charge. So you, whoever is interested, actually can join actually HISP, because actually University of Oslo, they have different offices. Like here in Africa, they have like 6 offices. HISP, health information system programs, so they can help actually to design actually the digital solution which can be used either for vaccination or any other program. So our vaccination program is the one currently fully digitalized. So other Ministry of Health program actually are under process of being digitalized, because very soon we will have one EMR integrating all health services, including vaccination. But before actually integrating with the EMR, so currently we're using DHIS2. And they have seen that actually there was a question related to how actually the system is used in remote settings. I would like to say that also that the system is being used also offline. It has features of being used offline. That is where also in investment we are always making. Actually, we are also providing tablet to health facilities so that can be easier also to track data on outreach vaccination sessions, and also where there is no internet connectivity. So I think actually those are the response I can provide. Thank you.
Thank you. That was great. Okay, Pawan, I'm going to put you on the spot now. I picked 3 questions for you, and one had to do with data control measures and what measures are put in place to ensure or improve data quality, and that's always a concern. There was a question, and I believe it's for either for Pawan or Hassan, but I'm going to pose it to you, Pawan, about community systems. And is this system, Hassan answered a little bit now, responding to tablets, but the same thing for the UN system. Is it just for facilities, or can it reach community systems? And there was also a question to you about nomadic populations and parents who move frequently, and how do you track and link these children to previous records, especially when they're not yet to complete their vaccines. And a question from my colleague Maki Osawa in JICA was asking about, do you plan to extend these tools to non-vaccine MCH services? So there's several questions for you, Dr. Pawan, if you want to try and answer them. Well, maybe Dr. Pawan got pulled away because I know it was a busy day for him. Okay, so while Dr. Pawan's coming back to us, I want to go to Tamoya, Nat, and Hassan. I'm going to ask a question actually to all three of you, and I think we're going to have to close on this. But everybody wants a tip. We've seen a lot of programs, you know, where it's pilots and they don't move to doing nationwide or to a larger system. So there's a couple of questions about, you know, how does a country know? Are there recommendations actually about when to embark on digitalization or a digital, electronic information system or digital home-based records? And just from the perspective of each of you, could you just say a few words to that? I think we can close on that question. So Tamoya, let's start with you. What would you give as advice, or what would you give as tips? When do you think a country, what are some signs of recommendations about when to embark on this process of digitalization?
Yeah, thank you very much. It's a very tough question because I think digital is because we are focusing on the home-based record, but digital information system is not only for users, but also the various levels of health system. So I'm not sure which part should be prioritized to digitalize. But many countries introduce EHS too, so that could be a start. And then gradually they are using the tracker system. And then probably our prototype, we plan to connect tracker system to share the data. So we can gradually expand digital tool to the users or mothers or children. So that could be a possible scenario.
Okay, before going to Nat, I want to pose another question to you, to Tamoya, because you got away easy with just one question. So let me ask you another one. We see this a lot in paper-based, and I saw a few questions on this in between the chat and the QA. A lot of times when we look at the home-based records where we see a lot of content, you know, some home-based records, particularly when they're integrated, have a lot of content. So if I'm going to move to digitalization, what do you say? Are we just assuming because it's digital, we can include all this content? Or would you say do you see when you were talking about the processes, do you see a way of, or necessary to prioritize certain information, certain record keeping? Or just because it's electronic, we can put everything in there? What do you think?
Yes, but the good thing of digital tool is it can personalize the advices or cares. So it can contain a lot of information, but it can select the necessary information for certain mothers or caregivers. So that could be an advantage of the digitalization of the home-based record.
Thank you, Tamoya. Nat, over to you. This question about when is a system or when is a country ready to embark on digital home-based records?
Yeah, I think that's a really important question, and there's unfortunately no easy answer to that because it really is country and context dependent. I think the biggest shift that we need to make in terms of how to approach digital, though, is that we always think about, okay, well, we have a problem, and then we want to find a tool to fix that specific problem. But when we actually talk about digital transformation, we have to understand that there's multiple problems that can be addressed by multiple systems working in conjunction with each other. So that applies to the home-based record as well, because when you think about digitizing home-based records, there's all these dependencies on other systems that need to be in place as well. But then there might also be prerequisites for those systems in place. So just easily with like an electronic immunization record, the hope is that if there's an EIR system in place, the health worker could just input into there and sort of print out a home-based record that then goes with the mother. But then in order to create an EIR, there's dependencies on, say, a health facility register or a vaccine product list or all these other things. And so when you think about it in the context of the entire health system, there's a lot of things that can be done in conjunction and strategically depending on where the dependencies lie. And I also want to flag too that we are within the health space, but as governments are embarking on this journey, especially as development funding is declining, we really have to think about this from a whole of government perspective as well. And so a lot of countries that have succeeded in digital transformation, and I think we've seen some examples here, is that they're not thinking about this just within the health space, but also how does the economics of digital technologies across government fundamentally change things and change the equation of how we think about prioritization within health. So that was a lot. We do have guidance on this though, so I would highly recommend looking at the Digital Implementation Investment Guide to start as a high-level overview. And then we also go into this in the introductory section of the handbook as well.
Okay, great, Nat. If you have a link, please put it in the chat to the Digital Investment Guide. Hassan, I don't know if you're still with us and you have anything to say about what, made Rwanda think they were ready to embark on this.
Yeah, so I would like to say that actually, so introducing digital solutions in any health system, actually it is never too late. So if I can go back actually in our history, when I started to think about digitalizing vaccination program, it was 2019, and immediately the same year, so we started. So actually the idea came from EPA managers meeting you had in Eritrea, Asmara in 2019. And then 6 months later, so when I came back actually in my office, I didn't know that actually we had a support of HISP. So I approached them, so and immediately we started. So what I can say is that actually each country can start. What you need is just to start small and keep improving. And if you look at you can look at where we are today with the system. It has improved a lot compared to what we have been using at the beginning. We have been able to integrate so many services like growth monitoring, like maternal death monitoring, like mosquito net distribution. So all of those features actually are very new. And currently we are trying our best to link with also vaccine management. So it means that actually what is required just to start. You can even start with very few districts or very few region, and let alone actually see how you can expand. And then coming back to the question related to sustainability, I would like to say that actually if there is something which is easily sustainable, is the digital systems, because sometimes actually the big investment is done actually at the beginning. So what is needed later actually is just a system maintenance, refresher training, and have a very good plan of replacement of IT tools. So it means that actually with the reducing funding from different donors, so today we are actually very comfortable because actually it is not compared as printing. We have been uh, waiting for every year for annual basis. So currently we can spend 3 years actually without actually having the need of additional funding to ensure that actually the system can run. So because actually you have IT guys actually everywhere in hospitals, so they are supporting a lot in maintenance. And on our side also, I can say that actually we have seen that we are benefiting a lot because actually have reduced the cost we have been using for for printing. Sorry, thank you.
Thank you. Thank you. That was really helpful. Pawan, I don't know if you're still there and you want to say any last words. Otherwise, I just want to say a big thank to the four of you and also to Laura. Excellent presentations. Special thanks to Alex Pascuto of TechNet 21, Nina Gerlach, a consultant to WHO, Rachel Belt, University of Oxford, who was actually the mastermind and helped us put this together. And of course, special thanks to Emily and the Octopus Translations team. It was so important you were here and we really appreciate your great service. Thanks to all of you for attending and we hope to hear from you soon. Our colleagues from TechNet will again send out the recording, the presentations, and we look forward to hearing about other country examples. So good afternoon, good morning, good evening.
Thanks
Thank
all.
you, Annie. Bye.
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 Bye.